So, Sherry kind of explained, I am a consultant. My full-time job is with Premier. Premier is the large group purchasing organization. It's not the Premier Physician Group. I was an emergency department nurse for many years before I became a consultant, consulted for a number of years, and then went back to practicing about 5 years ago. So just worked 8 hours Saturday night. I love it because it really allows me to practice and see what, if I ask somebody to do something, it's not something I wouldn't ask of myself. So that's pretty important to me. And I recognize the acuity and how the changes have occurred over the years. What we're seeing, and I'm nationwide, I pretty much can consult all over the place. Premier is both group purchasing as well as data analysis, so we have a lot of comparative data. And so I'm able to get out there and see what the trends and issues are. Certainly we're seeing increased expenses. Our organizations are actually bringing us in to do transformation projects. You probably heard that term or seen it, where they really want to look at staffing and supply chain and how can we reduce expenses for the hospital. We have reduced revenues. Our payer mix is changing. I was looking over this and I just thought my husband just had a total knee replacement 2 days before Thanksgiving. So I got out of town this week. It was kind of a good relief after 2 weeks of nursing, and he had it as an outpatient. He never went in the hospital. So that was a good payer that hospital is not seeing the money anymore. He did it, they spent one night in an outpatient ambulatory surgical center. So the hospitals are really going to be, you've seen it. Once they built this surgical center in our town, the money, all of the outpatient revenues are now going over there. So the hospitals are really struggling with the change in what their revenue used to be, what they predicted it to be, and what it isn't today. Uninsured patients, we all see them. The increase, we hear about it every day. The staff back to work, I don't know what you all are seeing, maybe on the West Coast, but certainly on the East Coast, we don't have a nursing shortage anymore. We don't see many travelers. The amount of travelers is, I'm seeing some, you agree? Yeah, nurses are coming back to work because of the way the financial climate is. Their husbands are out of work, or they're out of work, and their husbands are coming back to the nursing in the hospital. So that's kind of a good thing for us, because based on Kevin's lecture, you get to be a little choosier and hold people more accountable, because there's probably somebody looking for another job. And I know what I feel is the physicians are uneasy. I hear it, the mumbling about what's going to happen in February, what's going to happen if the whole payer mix changes. So there's an uneasiness, and I think I see it play out a lot of times in the role of protocols, and if we don't have enough physicians, well, then there's more put on the nursing staff, and we'll talk about that later when we talk about physician and nurse staffing. Increased regulatory pressure all the time to keep within the regulations of EMTALA, et cetera. And so what does this really mean for operations? Well, when Rick asked me to come and present, it was, I think, last year when we started this course, he said, I said, what do you want me to talk about? I got a lot of things in my little toolbox. And he said, after 17 years, now it's 18 years of consulting, just tell him what you know. Tell them what you learn. I thought, put it in 45 minutes, that won't be difficult. But what I really sum it up to be is that what my job is to help leaders like you balance these three things. And whether it's in the emergency department, in the hospital, but you're constantly balancing your volume against your staff and rooms, which if you don't have rooms, it doesn't matter how much staff you have. If you don't have staff, it doesn't matter how many rooms you have. So you have to balance those two together, and you balance against your length of stay. Perfect example, I had a call this week from a physician who was asking about our database, and I'll talk about that in a minute, but he said, I want to know how many rooms we should have. Well, I can't really tell you how many you should have. I can give you some comparative data about that, but how many rooms you should have really it depends on what your volume is and what your length of stay is. If you've got a length of stay of 4 hours, you're going to need probably twice as many rooms as somebody who has a length of stay of 2 hours. So it really, that balance, and if you can keep your length of stay low, then you can reduce your number of staff and even your rooms. We heard one of the lectures yesterday that said Freeman and White, John Huddy, I believe, always says you can't build an ED big enough. How many architects is not going to say that? You know, that's what the architects do. They want to build big ERs because it's more money for them. Well, once you build it, they will come, and then you don't have the staff for it, and I see that all the time. Or we've got too much staff. I've seen the problems where you have too big of an ER. And I worked with a hospital in Florida, Holmes Regional, for about a year, quite a few years ago. And they were up to, oh my gosh, I think 60 beds in the ED. They were out there looking. There was a PICU that was, it was empty. And the ED manager, we were interviewing some of the other department managers, and they said, yeah, Barb wants the PICU. And we're like, and I thought, why? Well, because she wants to put some of her patients there. Because the ED patients were staying 24, 36 hours in the ED. And so it doesn't, you know, step back and think about that whole scenario. When you're out there looking for additional beds, something's wrong. Okay, so too many beds is not always a good thing. So, you know, if you've got that constraint, then you certainly have to look at how do we balance our length of stay and our volume. So that's, you know, if you think about that, that's your job as a leader in the ED. And then you've got to do that against what kind of leadership skills and abilities, what kind of support do you get? Are you the redheaded stepchild of the hospital? Are you, you know, the one, and I truly believe that organizations, if it's just one department, if it's just the ED, that's bad, I can deal with it. You know, and then you're the ones that are out there screaming and say, fix the hospital throughput issue. If you could only get rid of, you know, get your admissions out of the ED, we could work just fine. How many feel that way? A lot of, right? If you could just get the admissions out, you could work. You have to do that against your risk and as well as quality outcomes, maintaining and making sure that you meet your core measures, reduce your left without being seen, reduce readmissions or readmissions to the ED, et cetera. Okay, so benchmarking. We've got lots of benchmarks. Premier's very well known for their benchmarks as far as staffing, as far as supply chain. We've got all sorts of data on how operations go. So why do you want to benchmark? I've been doing it for 18 years, so I absolutely depend on it. Because if I don't have comparative data, it's just Jeanne McGrayne and her opinions coming in your organization to tell you what to do. So I definitely rely on benchmarks to understand where are the opportunities. Are they in the door-to-doctor process? Or are they in the doctor-to-dispo process? Or are they in the lab? A lot of times we collect data to show people how good they are doing. You know, lo and behold, you're doing a really good job at getting patients discharged. But getting them admitted is another story. That's the kind of feedback we can provide. A lot of times everybody wants to point, it's the lab. Oh, if the lab could just get those blood specimens back quickly. And then we go in and lo and behold, it's not the lab. It might be getting the specimens to the lab. So it's, you know, understanding objectively where your opportunities are. To set goals, certainly understand what's realistic, what's not realistic. Is a 2-hour length of stay realistic? Is a 90-minute fast track length of stay realistic? I don't know. It depends on your constraints, and depends on your volume, your acuity. So understanding more about you is why you benchmark. How do I compare with others? How do I find peer organizations? People, you know, you can either use the benchmarking as a hammer or a hook. You know, you can use benchmarking, the tool that we have, and it takes some time, and because our setup is with these guys, I'll be glad. I brought my computer down. I'll be glad to show you the Premier comparative database. It's free to participate. You just have to email me. I'll send you the data survey. You send it to us. You get all the data back. And it allows you to pick your peers. So depending on what you're looking for, you have certain abilities. It may be you want to choose by volume. It may be that you want to choose if other urban hospitals, other rural hospital, all depends. It may be if you're choosing an information system and you're looking for other hospitals that bought Meditech or implemented IBEX. What are they doing? How did it go? You can pick up the phone and call these your peers. So that's why we benchmark, to understand if you find a better performing organization, I want to talk to you. Rather than I'm finding a better performing organization and it's the CFO saying, how come you can't get to 1.85 worked hours per visit? That's where benchmarking gets the bad rap. So you want to find better performing organizations, understand what best practices are, what are people doing. If your mode and your mindset, and I applaud Sherry and Kevin, everybody that's spoken has really been about, you've got to embrace improvement. And how can I go out there and find and learn from other organizations? So in our benchmarking database, we've got over 104 hospitals participating. It is quite large, the amount of data that you have to submit, because we get down to asking you, what is the time from the time you order an x-ray to the time they transport the patient, to the time they return, to the time you get the result. So if you're getting that level of data, it does take some time to fill it out. I show this slide because it shows the volume of all the hospitals participating. Now, if you're a 10,000 or 20,000 visit ED, you're not going to have that many other organizations to learn from. If you're in the 40,000 visit range, you probably go plus or minus 10,000 visits. You've got a lot of peers. If you're up at 100,000 visits, there's not that many people or organizations that are similar to you, so you've got to go out there and really, and that's why we're constantly trying to build the database, get more participants so we can all learn from each other. And that's one of the key, I think Sherry mentioned in her presentation yesterday about what defines you and what measures. Clearly, this would be one of how you are defined. Those are the things that I usually say the criteria. When you choose people who your peers are, your criteria should be those things that you cannot change. I remember years ago we were working with a hospital in Nashville, and they only wanted us to compare them with other hospitals that were doing open heart surgery. Well, they were only doing 2 a month. So our question was, well, wait a minute, maybe they shouldn't be doing open heart surgery, and maybe we need to open up and look at other organizations. So don't restrict who those organizations are you can learn from. There are definitely things that a 10,000 visit ED could learn from a 100,000 visit ED and vice versa. But volume is probably one of your key measures or comparative indicators. Certainly individually you want to benchmark against yourself, our performers. How did we do? What's our volume been over the years? Do we have a seasonal volume? Is it a regional volume? Do I have, certainly I've been doing some work down in Florida, and actually I think the next slide is a Florida, and you can see the definite difference in volume. This was an organization that actually their volume has decreased over 4 years, and this was very southern Florida. So understand it. The other thing I want you to think about is when you collect your data, don't do it based on just months. Do it on average daily visits by month, because otherwise your February always looks worse or better. So think about that. Look at your average daily visits and compare your processes. Excel, the new Excel's got all sorts of graphing capability to show different ways that you can display data. Also look at your arrival patterns by day of week. Now, this is interesting, not only day of week, but by month, etc. But if you're having, this was an organization that definitely had a variation in volume from Sunday to Wednesday, or what is it, Sunday to Tuesday. So on Sunday, we're a 45,000 visit ED, but on Wednesday, we're really a 52,000 visit ED. So when you're sitting down with architects, you don't need to go on the average volume. You need to look at how, what's my capacity based on day of week, based on, a Tuesday in January, let's go and plan this ED based on the largest amount of volume that we're ever going to see. And then certainly by hour of day, and Sherry kind of showed you some of these graphs. You want to look at arrival patterns. That is key. There's probably not one organization I've been in that you couldn't get at least the arrival patterns because finance gets it. Payer mix, you want to understand where is our revenue? Are we going to have the money to operate the department, to do the things that we need to do? And maybe we need to make changes. There are some facilities that I've been to that the self-pay is up to 46%. That's bad. You know, and so therefore, what does that say about, do we need to make some skill mix changes? Do we need to hire some mid-levels? On the other hand, if you've got a very low self-pay and people are choosing you and you're in a community that's very different. I mean, I live in Pinehurst, North Carolina. If anybody knows about Pinehurst, it's the big golf capital of the world. We have a lot of very well-paid, you know, people who are retired military, et cetera. We've got a great payer mix. So they come in expecting very good care when they, you know, when they present. Not to say we don't, you know, I'm lucky enough that everybody gets that care, but it may be different than if you're in downtown the Bronx, and or in some of the communities that I've been in, where especially Arizona, Phoenix. The payer mix is very different. So understand what your payer mix is. This is the comparison data, so you have it. Acuity, again, very important to look at. How do I, it's not for me to judge. I'll usually go in. Now this is our comparative data, so again, you can use this to compare your organization. But typically, if I was in looking at your data or helping you understand your organization, I'd have this slide up against each other. How does your 5-level system compare to the, the benchmarks? And very frequently lately, what I've seen is people that have adopted the 5-level system, but I do the data analysis and it looks like a 3-level system because nobody's using the 1s or the 5s. So it just indicates, well, maybe there should be some education going on. I'm sure you're seeing some 5s and 1s. So very few, 80% of the hospitals are using a 5-level system now. We look at 2 data points for admissions. One is what % of your ED patients are admitted. That's a key benchmark as to how I pick your criteria for comparison. A hospital, and that's one of the, I don't know whether, I always have the ability to pick both volume and admission % because that gives me the ability to look at acuity. An ED that's admitting 33% of their patients compared to an ED that's admitting 10% of the patients are completely different. Okay, so if that's, if you're one of those that look, the highest in our database is 41%. That's huge. I'd have to, I definitely want to go in and say, well, should they all be admitted? But it very well may be. I was in a place in Jackson, Mississippi that strategically put a lot of non-urgent care centers in the community, so because they didn't want to grow their ED visits, but their acuity was very high. They were admitting a large % of the patients that come in. And then the second one is, of all the patients that get admitted, what % come through the ED? Average being 54%, median 54%. I've seen this grow. It's been 45% over the years, and now it's just, because we've got our hospital, we just got the letter that my husband, he got the letter from his doc saying, I will no longer be your doctor in the hospital, it will be a hospitalist. We've got a complete medical staff of hospitalists. I think 90% of the patients admitted are hospitalist based. Guess where they're coming in? They're coming through the ED, the majority of them. So, so we're seeing a lot, that number increase just because of the advent of hospitalist services. So, back to our diagram. Now we looked at volume. Can you change your volume? I don't know. We worked with an organization where the CEO, they said, we would like you to come in and help us change the payer mix in the ED. Okay, I mean, why not? And why they were saying that was because the for-profit organization was taking away all their for-profit, their profitable patients. So, you know, understanding what your volume is, can you change it? Can I react to it by day of week? Or react to it by staffing or whatever I need to react to. Now we're on the other corner of that diagram, which is length of stay. Can I change my length of stay? And, you know, at least you've got the ability to manage what to the point of discharge, you can manage what's within your walls. Now, understanding there's 3 parts: the door to doctor, doctor to disposition, and then disposition to discharge and admit. Now, if you can, I put this slide together for my own benefit, basically, because it helps us understand. And I've been presenting benchmarks a lot of times, and you know, a lot of people like to collect data and analyze, analysis paralysis. Collecting data doesn't do anything, okay? You've got to act on the data. So collect the data, understand what it's telling you, but understand that it's for a purpose. You want to collect data so that you can either react to one of these different areas. So these are each one of the processes that you're evaluating. So if you're looking at your door-to-doctor time, understand that you have to then understand how that affects your volume, how that affects your, you know, that registration needs to be at the table when we talk about door-to-doctor time. That patient, who's doing patient placement? Is it the triage nurse? Is it the charge nurse? Is it the pull process? And who's, you know, fast track assignment? All of those, your door-to-doctor time is affected by all of those different processes. Same thing with your doctor to disposition. What processes are affected by that time? So when you do measure it and you see that there's opportunity, then you go back and say, well, is our information system working for us? Do we have the good skill mix nursing to patient ratios? Or maybe are we bringing our PA in too early when it's, you know, we really need a physician? And that's why our doctor to disposition times are too long. So this is really for you to take back with you and say, all right, if we're measuring this time, then we're analyzing these processes. Same as dispo to discharge. We'll talk about the consultant and hospitalist response as I mentioned when we talk about the admission process in the next lecture. But what are the incentives? Do you have cash collections? Is there a way to communicate that a patient needs to stop by the discharge office? We, in the organization that I work part-time at, have been collecting ever since I worked there back in the 80s. It was the early 80s, as a matter of fact. We always brought that patient around to the collector, and we actually give them a bill. Anybody, can anybody do that? I've never found anybody that does it, but I'm shocked, you know, because it was always a process. You got the bill at the end of the visit, and what's nice about it from a leader is that you get to fix that issue right then. How many of you get complaints when they get their bill, right? If you had the opportunity to look at the bill and say, well, how come I'm getting 2 Dermabond charges? You can explain it right then when they have it, as opposed to, I think, I've seen where I think Kirk Jensen did a presentation where he said it costs about $500 every time you look into a complaint. So that's, you know, it's a valuable process to get to that ability to say, here's what we did for you today, here's what it's going to cost you. And I always say when you give them a $5,000 bill, you know, and they're under the influence of narcotics, they're more likely to pull out their MasterCard. So, and the other thing is, you know, they were in pain 3 hours ago. They were in severe abdominal pain. 3 months from now, and by the way, you didn't really do anything for them anyway, and now they're getting a bill in the mail for $3,000, you know, that it just doesn't connect. So we can do a whole presentation on cash collections. Inpatient bed availability and nurse staffing, again, that's all going to affect your doctor or your disposition to admit time. Again, I'm not going to go over these, but if you want to look at what is the data that's going to be meaningful to me, go back and use this as a checklist. What can I get? And what can what am I looking for? And when you evaluate it and compare it, and I'm going to give you all those numbers to compare yourself to, then you can say, where are our opportunities? We may be doing a great job at getting the patient dispositioned, but we can't get them to a bed. Okay, so here's our, the way we look at data is the quartile and the median. Most of the, so basically the median is if we line up the 104 hospitals in the database, the 50th percentile is the median, the 25th percentile is the quartile. A lot of our data at Premier comes back in deciles because of the top decile hospitals with the HQID project. But here, quartile is about enough as what we need to see. That's kind of like what I see as the better performers, if they've got all their other outcomes good. So door to bed, overall, median is 34 minutes. Now when you start thinking about the stroke criteria and AMI criteria and things like that, 34 minutes is a heck of a lot of time. So, we've also break it out by admitted, discharged, fast-track patients. Before I came back to Premier, I never really looked at fast-track times. I don't like to look at fast-track times because fast-track is really just an operational way of making things, dedicating resources to a certain group of patients. Unfortunately, when you monitor fast-track times, you'll get a CEO or a COO or somebody come back and say, I want to see your fast-track times in less than 90 minutes. And then it becomes your criteria. Well, if I can't get that patient in and out in 90 minutes, they can't go to fast-track. And then I see a lot of empty fast-tracks. So be cautious about measuring and monitoring your fast-track. I'd rather see you be able to monitor it by level, by level 1s, 2s, 3s, 4s, 5s. Bed to doctor time. So once you get them to a bed, well, back to the door-to-bed time. So what are those things that influence your door-to-bed time? Again, do I have enough beds? Do I have enough staffed beds? Do I have the right triage nurses on? Are they able to assign the bed, or am I waiting for a charge nurse to give approval to get that patient in a bed? Do I have an information system that allows me to see what the workflow is so I can assign that bed? So you understand, don't just collect benchmarks or collect times or measures for the benefit of collecting. Do it so that you're making an impact on what the process is. What affects bed to doctor time? Here's a test. See if you're paying attention. Why would I measure bed to doctor time? Huh?
Big satisfaction.
It's a big satisfaction, but what are you going to do about it? You can say, oh yeah, our bed to doctor time is 50 minutes. They're not satisfied. But what are you going to change when your bed to doctor time is 50 minutes? Huh? Your staffing? It could be your process of getting the patient in. I think one of the presentations that Brent presented yesterday about lean and about the pull process, I worry about that because I'm very much a supporter of triage nurse assigning the beds. I got an empty bed, that patient goes to it. If I'm in the back, and I know, because I've got 4 beds, we have a 4-to-1 nurse-to-patient ratio. If I've got an empty bed, I'm getting a patient. I'm too busy to go and look and pick which one I want to, and that's what worried me about that is, do the nurses have the ability to pick which patient they get next? So very valuable processes having that triage nurse kind of push. Bed to doctor is, what's my doc staffing? Do I have enough docs on? Are they on at the right time? Are they the right skill mix? So clearly that affects your bed to doctor time, and that's really what I'm saying is you have to understand why am I measuring it, and what are those processes that are going to change if I find that there's a difference. Doctor to disposition, so once they see the physician, time seen by the doc, disposition is the time that they have made a disposition whether to be admitted or discharged. Not, well, I think, not, well, okay, all the labs are back, let's get some more. It's the time that basically, that's the definition, the time we've decided whether they're going to stay or go. And this has been very consistent. Overall, 120 minutes. I remember my numbers back at VHA, it was 111, it's 108. This is not really the time. Well, it depends on your organization, but most of the time I see the problem is before they get to the doc and after a disposition is made. But yet, this is definitely reflective of your lab turnaround times, your radiology. If I can't get a CAT scan read, I can't make a disposition. So it goes into a lot of other uncovered opportunities. And then disposition to depart. Again, we've got it based on admitted, discharged, fast track, and overall. So 52 minutes on average. You can see the difference. Admitted 138, so that's 2 hours and 18 minutes. How many of you are able to get your admitted patients out in 2 hours and 18 minutes? Not too many. I know we are. I know we are because it's probably less than an hour that we're getting beds assigned. Our hospitalists are actually incentivized to respond to the ED within 30 minutes, and then you got orders, and then I usually have a bed before I have orders. How are they incentivized? Financially. They monitor their response times, because they'll come down and cuss out an ED doc if the doc has called them and not documented what time they called. So they get a bonus. They get their bonus if they have their average response time of 30 minutes or less, a certain percentage of the time. So there's an incentive there. There's an aligned incentive to get them down there and get orders written. And then overall, length of stay from arrival to departure, just again, we've got some benchmarks here. So some very door-to-doctor best practices. You probably heard a number of best practices over the last 2 days. Quick registration, I mean, we've been there. Yeah, I remember 10 years ago, 15 years ago, saying, okay, how many's doing bedside registration? And you get 2 or 3 hands and say, oh, but it's the best thing to do. Now, who's not doing it? I mean, EMTALA it requires it. It's just, it makes sense to get that patient quickly to a bed. But I want not the triage nurse to be the first person. I'd like somebody else to be there collecting that information. So you don't have 10 people lined up and you find out that number 7 was your chest pain or number 6 is your stroke. So you need to have somebody out there collecting the information, brief triage assessment, but not too brief. I mean, I've heard a lot of people say, Rick, as a matter of fact, where is he? He's not in the room, I can say anything, but he would always say, oh, what do we need triage for, right? How many of you feel like triage is an obstacle? Oh gosh, look at you, yeah, it can be, but on the other hand, I've seen where you don't have triage and the patient just gets brought to the bed, the doc goes to see the patient, there's no vital signs, no allergies, no meds. So that's why I said be cautious about being too brief. It's a valuable step in just collecting information. Now, if you're doing thorough workups at triage, that's a different story. Triage assigns a room, I talked about that. Active use of the acuity or status column. We use WellSoft. I'm in a completely paperless ED. And it's a wonderful thing, but the ability, we have a status column that is absolutely critical that communicates. We call it the tag you're it system. So the patient gets put in a room, the triage nurse assigns the doctor and the nurse, and then she says MD evaluate. So that's the way, that's when their time starts. And then they click it when they're going to the room, when they come out, they do their orders, and then it's tag I'm it. So I have to do the orders and make sure it's done. Did you have a question? Right.
Available or quick triage is obviously appropriate, but if a patient is consigned to a waiting room for 2 hours, then obviously you need to change the duration of time and the extent of the evaluation.
Right. There's departments where the charge nurse is clearly in charge of the department and decides when those patients come in and go out, and then there's departments where the triage nurse is that person. Depending on what your volume is. If you're 100,000 visit ED, you might have 2 or 3 triage nurses pushing patients in at all times. But I have the utmost respect for the triage nurse, to the point where if anybody goes out and complains about the triage nurse, they have just bought that position, okay? Because it's the hardest, I think it's harder than the charge nurse job. Because, especially in my organization where you're assigning the beds to the docs and the nurses, you have to have really thick skin. But they're the patient advocate. And if they're not putting the patient in the room, they're responsible for that patient. You know, it's the California law's ratios, 1 to 4. 1 to 4 for the nursing staff, 1 to 2 for ICU patients, and in the ED 1 to 6. They never did a ratio for the triage nurse. Okay, you could have 20 people in the waiting room, and that's not okay. Yeah, I was in a hospital in Denver where I remember going through the ED, 60-bed ED. There were beds all over the place, and I get out to triage, and there was a nurse out there with 9 charts lined up. And I said, why aren't you putting patients in the back? And she said, well, we have a 1 to 3 ratio. And I said, so why is it okay for you to have 9? And she looked at me like, wow, I never thought about that. You know, but really, that's what it's about. And nothing can happen until they get to the back. So, you know, it's empowering that triage nurse to push till full is really what I believe in. And you have to be, you know, if they've got 3 patients in line and I've got an empty bed and they know I'm not very busy, they'll just send that patient back to me and I'll triage them at the room. All our EMS is triaged in the room. So, and our triage nurse is managing all EMS calls too, so.
One more quick question.
Yeah.
Sorry. Is it common for example, nurses to become quite defensive and protective of their roles, especially in the background of, say, the medical directors trying to change the triage process in other disciplines?
Oh, absolutely. We own triage, right? Nurses own, we made it up, I'm sure. We invented triage, so don't you tell us how to practice, I'm sure. That would be like us telling you how to, you know, how to practice as well. So absolutely they're defensive. Did I sound defensive? No. Yeah, it's very common, but it's critical. It's critical to your left without being seen rates. It's critical to your risk of patients, you know, who are. Did y'all just see just in the news, Frankfurt Hospital? I can say because it's on the news. The guy that was came in with chest pain, radiating into his arm. They waited in the ER waiting room for 35 minutes until he died because it was all on tape. When somebody came up and stole his watch, and 45 minutes later, somebody recognized him as being dead in the waiting room. Now I've been to that hospital. It's not like, you know, I'm downtown New York. It's outside of Philadelphia, but this just happened 2 or 3 weeks ago. It's all in the news. You know, so it's all about the triage nurse. You know, when we talk about the patient flow on the inpatient, it's all about the triage nurse. So we have to, you know, definitely make sure that that process is working well and we're there to support them. So, okay, ED tech is always assigned with the triage nurse because you can't leave triage empty. You can't have the nurses bringing the patients back and leaving the front door open. You hang a sign that says emergency. It does tend to bring sick people. So beds are made available, so you're constantly moving the beds. One of the things I like the charge nurse to focus on getting patients out, while the triage nurse focuses on getting patients in. Fast track criteria is flexible, so you're not just, you know, you don't have such a rigid criteria that you can't utilize those resources. The beds is the staff. Staff pull patients when triage, that's your being flexible. So if the staff sees that we're building up, and we can clearly see that in the waiting room. I just did some work down in Phoenix. One of the only things we did that made a huge impact was we put a board in the back. Nobody in the work area was aware of how many patients were at triage. We did that, and the left without being seen rate just plummeted because now the docs were like, whoa, we had no idea how many people were in the waiting room. So communicating that, having a tracking system, and aligned ED physician incentives. So that is, we got lots more. Free the charge nurse, I mentioned that. Pre-assign your nurses to the rooms. It's not, you know, back in the 80s, it was yeah, they're all our patients, right? Now, you can't do that anymore. You have to have accountability from the time they come in the building. Physicians pre-assigned to the rooms, therefore it's a team. How many of you are doing that? Docs pre-assigned to the rooms? What do you think about it?
Useful for team.
Huh?
It's very useful for teamwork.
Exactly. It's useful for teamwork. That way I know. I worked with a hospital down in Southern California who had, the nurses were having, I think, 4 to 5 patients. And he said, Jeanne, I could work with 4 different docs. And I don't know, one's telling me, no, get this patient discharged. No, get this one admitted. No, get the labs redrawn on that one. So at least I'm working with one doc and they're communicating, you know, yeah, I want you to prioritize this patient, this is what I think we're going. Okay, so good, big supporter of that. Teamwork, reduced variation, so you heard the lecture this morning on Sherry on standardization. Everybody, those are the things that make me nuts when I work, is when I go to the box that the urine collection system is supposed to be there and it's not there. Or I go to the other storeroom. Those are the things that take time out of my, my length of stay. Protocols so that care is anticipated. I'm not a big fan of triage nurses doing a lot of ordering in the waiting room. I've seen it where they're doing CAT scans. And the reason I say that, we could do a whole presentation on that, is that you're ending up with a lot of, let's see, we saw a CAT scan that had a glioma and the patient left without being seen. They were never registered. We had no way of getting in touch with them. We're finding that you can't bill patients, or you can and they're mad because you did my chest x-ray but I never even saw a doctor. Are you kidding? Putting too much, almost too much autonomy in the triage nurse. Again, back to, I think Kevin said yesterday, every one of you, every order that you have is going to be tied back to your ordering number. So be careful, and a lot of you, it's the medical director when the medical director is home in bed. So I'd much rather see protocols where everybody knows when we get a hip fracture, we're all going to treat it the same way. That's reducing variation. Rapid lab turnaround times, appropriate point of care testing, and dedicated radiology. Depending on your volume, if you're a 20,000 visit ED, you may be the only radiology center, but certainly anything over 40,000, you should have your own radiology suite and your own radiology staff. Not in your cost center, but in your department. Measuring and monitoring disposition. I think I've got the slide on that. Wait a minute. This is me. Sherry, I think, talked about giving data back to physicians, where she hung up their comparative data. This is at RN discharge times. So this is actually from the time the doc says discharge the patient to the time the nurse signs them out of the computer system. And I did not know that they were doing this. And when I was just learning, one of the nurses came up to me behind me and said, hey, do you want me to discharge that patient of yours, or your numbers are going to look bad? And I went, what numbers is she talking about? And then I went in the break room, and lo and behold, they were hanging up our numbers. Now, I was not real good at the time. This is when I first realized it was happening. I was 26 minutes. See, I'm a dark yellow. That's not good. And this is when we were doing fast track, So you see, did that change my practice? Absolutely. You give a nurse, an IV to start, let's see, an admission that they've got to get ready, and a discharge. Which one is she going to do last? The discharge. Why? Because you're going to get another patient in that room. Well, not in our organization, because you don't want your numbers to, you don't want to be embarrassed by everybody else. Yes?
So question, the door to discharge time is also measured for the doc, right?
Door to discharge, I think the docs definitely share their data. Not, no, the docs are only measured to the disposition time. From the time they see the patient to the time of disposition. That's it.
It seems to me, though, that you would probably want the doctor to take ownership of that entire time. And a radical idea
Sherry, what time?
of the doctor discharge the patient. If you're interested in your times, you'll routinely add 25 minutes to a patient's visit. You're not going to get a 2-hour door to discharge time if you routinely say that's the nurse's job. And it's for the doctors, it's the last chance to get it right. It just takes a few minutes to do it. It's closing the visit. It's the end of the show. A lot of doctors will push back and say, no, no, no. But this is adding 25 minutes to a visit unnecessarily ready
Right.
to go, and if you're not ready to get them out the door.
So that's what we did, and the problem there is that because of that, if the patient's still up there, the doc sees it, the doc says, forget it, I'm discharging this patient off the board. I've already taken care of discharging them personally, but I'm waiting for it to come off, and because their times are being monitored, I'm unable to monitor nursing compliance, disposition to discharge, and the docs are just getting them off.
Yeah, see, when our docs hit the discharge, they are done. They have written their discharge instructions, they do their typing of the discharge instructions, they have, the prescription is printed out, and all I have to do is go into the room, do the education, you know, what they have done already, and get the patient out of the department. So, yes.
And how do you accommodate for, I mean, they can write a discharge order, but there may be special instructions saying after, you know,
It's rare. That does happen, and we have the ability to, on our tracking system, remember that we can change the status to hold. So if I have to give Rocephin, or you know, something that I want to wait 20, 30 minutes for, then I can put that patient on hold and then change it. But that's so few of the times that the majority of times this works. Y'all, it works because, and we've also got to monitor that it will turn blue if you've gone over 30 minutes, so you're going, I got to get it done. So that's how using data to drive performance in practice. It makes a difference. This is discharge planning begins on admission, smooth collection process, automated discharge instructions, initiated by the physician and reviewed by the RN with the patient. So clearly, I've seen nurses, oh my gosh, I was in one organization just recently in Virginia where the docs were handwriting the discharge instructions, handing them to the nurse, and then the nurse sat down and typed them into the computer. Now, it sounds silly, but I'm not, some of you, it may be happening in your organization. So look at those redundant practices, because we've always done it that way is not okay anymore. This is just a trending of physician length of stay by doctor, and we just did A, B, C, D. You can see the PAs were down here at the very end. They're seeing far more, but in less time. We actually use data to look at triage nurse practice. Interestingly enough, this was the count of the number of times that nurse was triaging. So KK was clearly, and that was one of the complaints we kind of heard in the interviews, that they, staffed certain positions all the time with certain nurses. So the data showed it. We gave this data back to the organizations to educate them on what they're doing differently. Look at the variation in times from the time the patient presented to the time they got placed in a bed by triage nurse. So, then you might stratify, well, maybe my night nurses, evening nurses, whatever it might be, but use data to understand what you're doing now. Okay, staffing, just really quickly, and I know Sherry's pushing to finish up, but we use Operations Advisor. This is a comparative data, so you can look at the key metrics, your volume, worked hours, total worked hours per unit. I think you can barely see it in this, but you can always email me and I can get you the numbers larger. But this is how your organizations look at how staffing and benchmarking and what are the lowest. This was probably a group with considerable, comparable volume. But then we look at how is it regional, national, comparative benchmarks. And then we look at skill mix. You've got your numbers in your packet so you can see, here they had far more non-licensed personnel, so many more techs than they did RNs. Did that affect their throughput? Absolutely. So understanding all of these numbers, you really have to understand it before you put all the picture together. How is their physician staffing, physician numbers or patients per physician hour? This is the average. Now we're at 1.84. I think we've seen it go down from 2.2 to 2.0 to now we're 1.8 as far as the number of physician hours, patients per physician hour. So the lower the number, the better staffed department you are, the higher the number, the worse staff. Now, would they say, well, what should my number be, Jeanne? It all depends. I don't know if I want to work where these guys are working as hard as they are. This is really not as many physicians available. But over here, here's what I see is in this department, we've got nurses doing physician work. In this department, we've got docs doing nursing work. Does that make sense? You know, when you got lots of docs, PAs, residents, they're putting the ankle splints on, they're doing nursing work. And over here, the nurses are doing ordering for the docs, they're putting the splints on, they're doing all the things that the nurses probably shouldn't be doing. We've got some data on ratios of nurse practitioner PA, your mid-levels, about 25%. And then for some of you who are medical directors, on average, the amount of time that they spend doing administrative activities is 35% of their time. Again, that all depends on volume. If you get the database, you can look at, I just want to compare myself with hospitals of 60,000 visits and above, and that may be 50% of their time. So that allows you to do that. We have a tool that allows us to look at arrival patterns and census and staffing, and it says here's the yellow is what the current is, and the blue is how they were recommended. So our physician staffing is based on arrival patterns, our nurse staffing is based on census, let's see, and beds. So if you look at beds, how many beds do I need? These are benchmarks, patients per bed. Big time, just, if I have 40,000 visits a year and I have 20 beds, then I'm seeing 2,000 patients per bed. Okay, that's just as simple as that. The average out there is about 1,479, 1,500 patients per bed. So these are your benchmarks. Do I have this place, they're seeing 3,000 patients a bed. They need an architect, okay? Or they need very efficient turnover time. How many triage nurses do you need based on volume? What's that?
When you say 3,000 patients per bed, does that include wheelchair areas and fast track areas?
No, that means beds. Unless you're okay with hall beds.
In terms of if you have a fast track area and you have no beds in your fast track area, you have 10 reclining chairs, is that a bed?
Then you can use it. Then you can use it if that's acceptable. If your patients are okay with chairs and just being treated in a chair, and you don't need to use that benchmark to say, or you might say, well, yeah, we're at 3,000 patients per bed, but we're using chairs too. We didn't count the chairs. Most of the time, the comparative data is based on beds, not on hall spaces and not on chairs necessarily. So certainly, again, this data is in your packet. And then we won't go and get into all this, but you can use volume and arrival patterns to determine how many triage nurses. This one, we worked with an organization that was building a new ED. And with the architects were basically just kind of pulling the numbers. Well, what do you think? How many triage nurse stations do you think we need? Well, we need data to do that. So we actually looked at the arrival patterns, and it really wasn't until they were up at 45,000 visits were they really going to need 2 triage stations. So same thing with pods. How many docs do we need by hour of day? At what volume? So it wasn't, and once they were at 45,000 visits, which projected them out like 15 years, that was when they were going to need 4 pod areas. So using data to drive performance, again, this is looking at a hospital that varied based on visits per month. In March, they needed 25 beds in March, where they only needed 20 the rest of the year. So be careful of averages. If you've got high volume months, you need to look at those high volumes. Your risk, left without being seen. Everybody know what your left without being seen rate is. Very clearly defined. If you don't see a doctor, then you're in the left without being seen category. It's not eloped. I've seen people have up to 5 different categories of left without being seen. It's like, no, you just need one. They either see a doc or they don't. So how to reduce risk, reduce your left without being seen, your team assignments, bedside report. Good handoffs, computerized order entry, huge risk reducer. Physicians responsible for radiology and culture report review, radiology transport to and from lab, radiology and lab order labels printing in the lab, not in the ED. Any of these practices, if you want me to, want to talk to me about it, just certainly email me and I'll be glad to talk. So, quality, reducing variation, you heard a lot about standardization from Sherry, and leadership, permanent charge nurses, having mutually shared expectations, get everybody on the same page, et cetera, and reward positive behaviors, frequent staff meetings, et cetera. So that's it.